Welcome back, everyone, to part 36 of our 150-part IPDRG masterclass. In part 35, we conquered the respiratory and thoracic systems. Well, today, we're heading further south to completely decode the intricacies of genitourinary and renal system procedures. So grab those ICD-10's PCS manuals because we have got some incredibly fascinating ground to cover today.
And hey, real quick before we jump in, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Your support is absolutely crucial because it helps us keep this entire massive masterclass completely free for you.
All right, here's our game plan for today. We'll start off with a high-level urinary system overview, specifically looking at endoscopy. Then, we'll tackle interventions for urinary stones. After that, we'll move right into renal surgeries and vascular access for dialysis. We're going to wrap up our deep dive with reproductive system coding before finally summarizing our next steps.
Section 1. Urinary System Overview and Endoscopy.
Okay, let's crack open those coding manuals to the medical and surgical section. As you already know, locking down your body system character is always the critical first step in building a valid 7-character PCS code. For today's explainer, we are going to rely heavily on 3 main characters in that second position. We've got T for the urinary system, U for the female reproductive system, and V for the male reproductive system. Go ahead and memorize these, because they are basically your home base for this entire specialty.
Let's kick things off with a foundational root operation, inspection, which is coded with the character J. The official definition here is visually and/or manually exploring a body part. So think about a routine diagnostic cystoscopy. The physician is using a scope via a natural or artificial opening, and they're simply looking around the bladder and urethra without actually taking any tissue. Because the sole objective is just to examine that body part, the root operation is squarely an inspection.
But wait, what happens if the doctor finds something abnormal in there, like a bladder tumor, during that cystoscopy? Notice how the physician's action suddenly shifts, and so does our root operation? If the doctor uses a sharp instrument to actually cut out a piece of that tumor for a biopsy, well, that's an excision, character B. However, if they use energy, like cautery, to perform a fulguration, meaning they are physically eradicating the lesion so it's completely obliterated and just no longer there, then it's coded as destruction, which is character 5.
Section 2. Urinary Calculus Interventions.
Stones. Treating urinary calculus, or stones, is a super common clinical scenario. But honestly, it constantly trips up new coders. Why? Because the root operation depends entirely on the specific technique the surgeon uses. Let's look at the clinical pathway. Say a patient presents with a kidney stone. The physician might try to break up the stone from the outside using shock waves. Or they might go in directly with a scope to physically pull the stone out. Let's break down exactly how these are 2 entirely different root operations.
First up, we have extracorporeal shockwave lithotripsy, or ESWL. Here, physical force is applied to literally break the solid matter into smaller pieces. Now, here is the absolute key to this code. The pieces of the solid matter are not physically taken out by the surgeon. Nope, they are eliminated naturally by the patient's own body over time. Because of that, the correct root operation code is fragmentation, which is character F.
Now contrast that procedure with extirpation character C. Extirpation is defined as taking or cutting out solid matter from a body part. In this specific scenario, the body part itself isn't the focus. The objective is removing that abnormal byproduct. Think about pulling a calculus out of the ureter using a basket during a ureteroscopy. You're physically, actively taking that solid matter out of the patient.
But hey, what if things don't go according to plan in the OR? Let's check the official ICD-10 PCS guidelines, specifically B3.4, which covers discontinued procedures. Say a ureteroscopy is performed to extract a stone, but the extraction is unsuccessful and has to be discontinued. What do? You code the procedure to the root operation that was actually performed. In this case, because the extirpation failed, it defaults back to an inspection of the ureter. The golden rule here, always code what was actually accomplished.
Section 3. Renal and vascular access procedures. Let's shift gears now to some higher acuity procedures involving the kidneys themselves, as well as the vascular access required when those kidneys fail and a patient needs dialysis. Picture a kidney tumor removal. A surgeon might cut out a portion of the kidney to remove the tumor, but they leave the rest of the organ totally intact. Seeing it that way really proves why this specific procedure is classified as an excision.
So it all boils down to understanding the critical difference between excision and resection. A partial nephrectomy, where you're cutting out just a portion of the body part without replacement, is an excision, character B. However, a total nephrectomy, where you are cutting out the body part entirely without replacement, is a resection, character T.
Now, when a patient's kidneys completely fail, they often need hemodialysis. Let's systematically break down how we code this entire process. First, the hemodialysis machine taking over the function of the kidney falls under the root operation performance found in the extracorporeal assistance section, which gives us the code 5A1D0Z. Next, putting in a central venous catheter for access, that's the root operation insertion, character H. And finally, creating an AV fistula, which physically reroutes the blood flow, is coded to the root operation bypass, character 1.
Section 4. Reproductive System Coding. All right, let's jump over to body systems U and V, tackling those gender-specific reproductive procedures we see all the time in clinical documentation. I want to read a quote directly from our coding guidelines to you. A prostatectomy is the removal of the prostate, while a transurethral resection of the prostate removes the section of the prostate causing symptoms. If you're taking notes right now, I want you to heavily highlight or underline that word section.
And that brings us right to a massive coding trap. A TURP, transurethral resection of the prostate, literally has the word resection right there in its clinical name. But because we just learned that it only removes a portion or section of the prostate, in ICD-10 PCS, we must code it as an excision, character B, not a resection. This is why you must always code based on the root operation definition and never just blindly follow the physician's title for the surgery.
Moving over to the female reproductive system, let's take a quick look at hysterectomy guidelines. When an entire uterus is removed during a total hysterectomy, it perfectly aligns with the root operation resection, character T. Why? Because you are cutting out all of a specific body part. Oh, and while we're on the topic, a quick pro tip on tubal ligations. If the surgeon completely occludes the tubes with bands or clips, it's coded as occlusion, character L. But if they sever or remove a segment of the tube, it jumps right back to excision, character B.
Section 5. Summary and next steps.
Wow, we've covered some incredibly important ground today, students. Here is a rapid-fire recap of everything we've decoded so far. I highly recommend grabbing a screenshot of this or copying it directly into your study notes for a quick reference later. Pay special attention again to that critical distinction between a partial nephrectomy as an excision versus a total nephrectomy as a resection. And whatever you do, don't forget about that tricky TURP code hiding in plain sight as an excision.
Okay, so we've completely mastered the surgical components today, but that leaves me with a final, really important question for you. What happens when we need to code the complex imaging for these exact same procedures? Surgeries like ESWL and CVC insertions rely entirely on fluoroscopy and ultrasound guidance. So how do we capture that accurately without making a coding error? Well, that is exactly the puzzle we're going to solve in part 37 of our masterclass when we dive straight into the ancillary sections for imaging.
Before we wrap up, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Thank you so much for your incredible focus today. Keep studying those guidelines, and I will see you all in Part 37.